first speaker is Dr. ARUN SAMPRATHI, who is the director of the SAMPRATHI Eye Hospital and Screen Center, and of course, an extremely experienced and a most complacent and a calm Dr. ARUN SAMPRATHI, whom we have great pride in knowing. And he is going to be talking on a very important topic, refractive errors in children, the art of prescribing glasses and signs of halting progression. Preferred practice guidelines.
So first of all, I would like to thank Madam for giving me this opportunity. Refractive errors in children, it's actually the most common problem we see in our
Dr.
clinical
Rashmin,
practice.
could you take the first?
We all know the pediatric refraction is not so easy because of the uncooperative child.
Please, so, audience to be quiet, please. The door to be closed.
So why at all we need to correct the refractive error? First and foremost is to improve the visual acuity, decrease the strabismus, enhance the binocular vision, and relieve the astigmatism. We all know children are born with the hypermetropic error, and as they grow older, the emmetropization happens. Assessment of refractive error is mainly subjective and objective, but in children we rely more on the objective methods because subjective methods may not be reliable. Determining the refractive errors needs an alert child because often we see refraction under anesthesia. So that's actually is the last resort unless you're not able to get a refraction, because if you're refracting an alert child, you're refracting the fovea, otherwise you may refract some other part of the retina. These are very useful pediatric trial frames and trial racks for the refraction, and as we all know, the importance of cycloplegic refraction cannot be undermined. It's also important to remember that refractive error correction alters the strabismus and always may not be for the better. So sometimes you may have a opposite effect. So that's why it's always very important to check the muscle balance in each and every child before you give the refractive correction. So hyperopic corrections, they decrease the esotropia, whereas they can increase the exotropia, whereas myopic corrections will decrease the exotropia and increase the esotropia. So this has to be remembered anytime when you are prescribing a glass to any child. So prescribing guidelines, I am sure you all know about this one. Myopia of more than 1.5 in an older child should be corrected. Less than 2 years, more than 4 diopter to be corrected. And hyperopic correction is a little more tricky because there are a lot of other factors which influence, just not the refractive error. The age of the child, the amount of hypermetropia, the accommodative abilities, and the presence or absence of strabismus. And we also have to remember this high hypermetropes, like you say +8, +9 you get. So these people have very subnormal accommodation. So that's why they have to be given a full correction, and we should not be undercorrecting in these children. And accommodative targets are extremely essential, and without that you can miss the esotropia and you may not give the proper correction for the hypermetropia. So whenever you have a hypermetropia with esotropia, we always try to give the full correction, whereas whenever it's associated with an exotropia, we undercorrect. But please remember here, just because exotropia is there and hypermetropia is there, doesn't mean that you should not give glasses. So it should be given, and you have to ensure that the visual acuity is optimal. Only then the exotropia will get better. So just because exotropia is there, we should not be correcting hypermetropia, but we always undercorrect the hypermetropia. Astigmatism, any astigmatism more than 1.5 should be corrected. And anisometropia, very important to remember the correction, the proper correction has to be given, especially in anisohypermetropia, because these children are highly prone for amblyopias. So even a 1 diopter hyperopic difference can cause a very severe amblyopia. So a word about the control of progression. Progressive myopia, as we all know, has become a big problem now, and the most important reason is the myopic macular degeneration has been hypothesized to become the most common cause of irreversible blindness in the future. So that's why we should focus on preventing the progress of myopia. So the currently available modalities for preventing the progression is, as we all know, the spectacle and the contact lenses, but now there is more emphasis on the environmental and the pharmacological modifications. Environment, at least 2 hours of outdoor activities has been shown to have a protective effect, because it's supposed to release dopamine, which actually helps in preventing the increase in elongation of the eyeball. Bifocals and progressive are also being used, and this is especially useful in children who have an accommodative lag. So there the progression of myopia can be controlled by using progressive glasses. Recently there has been a lot of interest about this DIMS lenses, the defocus incorporated multiple segments. So here what happens is there is a central treatment zone, and around that the central clear zone would give the good visual acuity. Around that there is a hyperopic zone. So basically what has happened in one of the hypotheses for myopia is the peripheral defocus theory, wherein the central rays focus on the retina when you correct the myopia, but the peripheral rays are supposed to focus behind the retina, so that is inducing the hypermetropia, and thereby it results in progression of myopia. Ortho-K lenses have also been used. I don't have much experience about this ortho-K lenses, and atropine has been the most promising. 0.01% gives the best results with minimal side effects. So atropine works not through the accommodative mechanism, but through the non-muscarinic and a direct influence on the scleral fibroblast. So in conclusion, outdoor time has been the most promising intervention for preventing the progression of myopia, and there has been a very consistent evidence that 0.01% atropine gives excellent results, and other things like ortho-K also can be used. But most importantly, we have to keep abreast of the ongoing studies so that we know what is the latest one and give the best to our patients. Thank you.
Thank you, Dr. Arun. Excellently presenting, especially about what we need to look out for preventing progression in myopia. And this is a continuously evolving topic, and we hope to learn for preventing progression for myopia. Any comments on or any experience on especially optical? We have, of course, now a good amount of experience on the pharmacological. So expert panel, any experience with the DIMS spectacles particularly, or the Zeiss
Myovision.
Specifically, whom do you want to ask?
We have
So
experiences
DIMS lens, we are prescribing DIMS. Only factor with DIMS is that some of the children take a little time to adapt to it. So we must tell them that it takes a little time to adapt to the DIMS lens, and it's a little expensive. But
Yes,
if you
it
make
sure
it in a
is.
package, it works out a little cheaper.
Yeah.
But one point I would like to make, you should measure the lag of accommodation.
Yes, that's very
Before
important.
you
It's
prescribe.
very important.
Very important.
So if you have an accommodative lag, what would be your preferred intervention?
I would probably give a progressive. along with atropine.
Then Dr. Pradeep, what?
The interesting part is that accommodation lag we are talking, but
But
atropine,
atropine, I would-
causes accommodation lag
Yeah.
and treats. So there is a, we have to be
Although,
very
I mean, one, in fact, when we had discussed it also, we had said that atropine in these patients, so it's you can argue both ways, because studies have not shown any change in accommodation on a low dose atropine. We
So I'm
haven't
saying
found.
accommodation lag is something which we may not be implying so much importance.
Yeah.
Then,
so
Dr. Pradeep, I'll ask you, what would be your baseline workup when the patient with myopia has been diagnosed for the first time? Like for the audience, what extra
So
things?
for first time, I mean, one is the proper refraction under the right cycloplegia for age. So less than 5, we are insisting on atropine ointment used 3 days prior. For 6 and above, we are using hometropine. Some people use cyclopentolate. And usually first time, even in adults, maybe 18, 20 years also, we are preferring hometropine for the first time, because they may be having pseudomyopia otherwise. That is what we should do. Secondly, axial length, if you are doing any treatment, then axial length should be done. Accommodation lag may be done. I mean, that's questionable.
Probably even hours of near work, indoor work, family history.
All
could
those
also
history
be
and all
asked.
those
History.
are the details. Yes.
Wonderful, we got all our answers.
So, of course, accommodative lag is something we should measure, and a baseline axial length
Yes.
and an axial length on every annual follow-up. Also, because we've seen the discrepancy in the effect on refractive error and the axial length being there, particularly for the pharmacological treatment at the present in the currently available. So it's important that you kind of document the axial length change, because effect in the end, that's what we are looking for, not refractive error, but the axial length change. So we'll move on
And
to
one
the
more, there is the esophoria. Esophoria on
yeah,
ear is
esophoria,
another factor
accommodative
which
lag.
is
Both these are very, very important,
yes,
and that's why we always insist that pediatric ophthalmologists should be the ones who should be dispensing treatment for progressive myopia and not others.
Thank you.